يلا يا شباب. مساء الخير. الحقيقة احنا انا بمثل سنوفي، وهتكلم على حاجة الحقيقة فعلا احنا يعني I'm going to talk about some hot issue actually about the cancer associated thrombosis. All of us actually meeting this kind of patient and this kind of problem actually, and usually we do care about this patient much more than the oncologists themselves. So we'll talk about this VTE risk in cancer patient, the guidelines for primary prophylaxis, guidelines for treatment, and RETICAT study, and guidelines for secondary prophylaxis. Actually, the cancer patient has all the arms of Virchow triad with hypercoagulability due malignancy, vascular damage due to the multiple venous puncture, circulatory stasis by sometime the direct obstruction by the tumor itself, and all the guidelines, especially the National Comprehensive Cancer Network, NCCN, actually once the cancer is diagnosed and they divide the patient to the surgical and the medical oncology, we're concerned about the medical oncology patient who will need to have prophylaxis from the first day he'd been diagnosed, and especially when he's starting to have the chemotherapy. And according to Corona score, they will have the anticoagulation for quite a period of time, up to 6 months. This is the predictive model for calculating the risk of chemotherapy-associated thrombosis, which is called the Corona predictive model. And actually, this score is dependent on the site of the cancer. Very high risk in case of stomach and the pancreas, high risk in case of lung, lymphoma, gynecological bladder, and testicular. And the pre-chemotherapy platelets count, if it is 350,000 or more, hemoglobin level less than 10 gram, or the pre-chemotherapy leukocyte count more than 11,000. All of this score actually put them in the low risk, intermediate risk, or high risk from 0, from 1 to 2, and 3 or more. Actually, according to the NCCN guidelines in primary prophylaxis, they are found that it have been recommended to use the apixaban and rivaroxaban and deltabarin with, of course, enoxaparin 1 milligram per kilogram per second daily for 3 months, and then cut it down to the 40 milligram per subcutaneously daily. So this is just to assure that the importance of using the low molecular weight, because in some of the cancer cases, especially if this cancer of the stomach or terminal ileum, which is a site of absorption of the medication, that WAC is not the option actually, and the low molecular weight and the enoxaparin is much more recommended in this case, and this actual recommendation is level 2A. This is again all the international recommendation for ambulatory medical oncology. Actually, they, as well as they recommend the DWAC, they also recommend the low molecular weight heparin. And actually, they agreed, especially the American Society of Clinical Oncology, on the fixed dose for prophylaxis VTE, which is 40 milligram once daily subcutaneously of enoxaparin. This is again the RETI score for bleeding risk. And now we will talk about the secondary prophylaxis. So the third most common cause of cardiovascular death following acute coronary artery disease and stroke is this cancer-associated thrombosis. the 20% of active cancer account for overall incidence of rate of the VTE, and second most prevalent cause of death in cancer patient is the VTE. The annual incidence of VTE in patients with cancer is 0.5%. Again, for therapeutic cases of they already have the DVT in cancer, the inexorabine is used 1 milligram per kilogram subcutaneously every 12 hours for 1 month, and then they cut it down to 1.5 milligram per kilogram daily for the first month. And then they may continue for 3 months or 6 months. This is again the summary of international recommendation for using the low molecular weight heparin. And the secondary prophylaxis, and this is very important actually, to keep the patient for long-term anticoagulation. The secondary prophylaxis now is totally agreed to be 6 months in the patient with cancer-associated thrombosis. And actually, RETICAT study is very important study of 10 years study for 4,451 patients, and that objective of this study was to compare the long-term effectiveness and safety for enoxaparin versus deltaparin and tenzaparin for secondary prevention of VTE. So this is comparison between the Kilixan, Fragmin, and Inohab. So they actually use the data from the multi-center, multi-international registry to compare the VTE recurrence, measure bleeding, death, and the patient were assessed for up to 6 months until the first individual occurrence of clinical outcome using the full dose of enoxaparin versus the other 2 drugs for 6 months. And that was the dose we've been talked about just now. And this is the proportion of the cases which completing the 6 months in this study. So the outcome including VTE recurrence, major bleeding, and non-major clinical significant bleeding, and all causes of death, and fatal or pulmonary embolism or fatal bleeding-related death. And this actually diagram we can notice that in the recurrence of VTE or the fatal or non-fatal major bleeding or non-major clinical significant bleeding, usually the very good result of the enoxaparin. It's again in the outcome of these cases is quite clear. There is actually in all causes there was no difference, big great difference between the all drugs. The results actually patients with cancer and venous thromboembolism should receive long-term anticoagulation therapy. RETICAT compared the effectiveness and safety of enoxaparin versus deltaparin and tenzaparin. There was no statistical difference between treatment and recurrence VTE. There was no difference between treatment in bleeding complication or death. The conclusion that of this study that enoxaparin regimen with the most favorable benefit-risk profile for the extended treatment of VTE and prevention of its recurrence in patients with active cancer was 1 milligram per kilogram twice per day, followed by the 1.5 once per day. So this is just the guidelines which recommended all this data, and the duration of anticoagulation recommended for 3 months or as long as 18 months. Again, the take-home message: cancer patient is a VTE high-risk patient, and for coroner score 2 or more, consider primary prophylaxis in cancer patient. Treatment of cancer-associated thrombosis is long-term anticoagulant up to 6 or even more than 6 months. And we have to be very confident because this massive study, the EVC2023 study, recommended this. And secondary prophylaxis in cancer patient, enoxaparin showed efficacy and safety for 6-month duration secondary prophylaxis. Thank you very much.
Thank you, Dr. Essam, for your excellent